A very good morning to one and all attending this important webinar. I will be covering the impact of early childhood caries on quality of life of families in India and time for action. First of all, I'm thankful to the organizers, especially the Sri Ramachandra University and Dr. MS Mathur and his team for organizing this event. So during my presentation today, I will be highlighting you with a different perspective than you know. So this is an example of the figure in which one side people are looking at it and they are thinking that it's a shadow of a circle. The other side people are thinking that it's a shadow of a rectangle, whereas in reality it is a cylinder. So that's what I'm trying to bring it to you. You are mainly the clinicians, and for you. So normally, what is the early childhood caries? Is the one or more decade non-cavitated or cavitated missing or filled teeth surfaces in any primary tooth under the age of 6, whereas the IAPD has little bit modified it by saying that filled due to caries. So this definition, we think for the clinician's purposes, it covers almost everything, whereas this may not be true. What we think, what we talk, and what we have studied throughout is just an iceberg of the problem. We know the problem as the visible caries, whatever we can see as white spot or a cavitated lesion. But we do not record anywhere suffering of the child, suffering of the family, effect on the family economy, and indirect impact on the siblings. So that's all is the tip of the iceberg. And I'm trying to cover all this in my this presentation. So what is not seen in our definition is some suffering of the child. We may record DMFT score, but we do not record mostly what is the status of pain. Is there any difficulty or inability in chewing or drinking or consuming hot and cold sweets? Sometimes sour fluids. There could be difficulty in sleeping, difficulty in socializing due to dental decay, poor school performances, deteriorating self-esteem, effect on the growth and probably the weight loss, irritation and frustration. We do not record that. And because we do not record that, we do not address that, and we do not look at as an outcome while treating the child. Similarly, what is not recorded and we normally do not record anywhere is what is the suffering of the family. It can be emotional trauma due to child's pain. It could be disturbed sleep for the family members, effect on daily home food preparation. I'm talking all these with the perspective of Indian population because we are really affected with one child having any problem. Then if we are going to hospital with one child, we have to make arrangement for hospital visit. We have to make alternate arrangements for home or for the school dropout for the other child. And if we have elderly parents at home, who will look after them when we go for the treatment of one child? Then we also gather workplace related, pending work related work stress because we take leave from our workplaces for getting our child treated. Then the effect on the family economy. So we know the direct cost, maybe it is a hospital or a clinic charging some X amount of money for the treatment. But what we do not record is the indirect cost of treatment. And what is that indirect cost, which is actually a larger chunk in most cases, is it's the travel cost from home to the clinic and back, the cost of medication, cost of leave from the workplace for the parents, or the loss of school hours for the child, loss of wages in case of a daily wages worker. Then there's an indirect cost involved with when the parents are out with a child. Then there's extra cost for the meal because something extra has to be purchased or something extra has to be arranged. Then indirect cost is also for special meal for the affected child and also arranging for the school drop and pickup of the sibling. Then impact on the sibling, which is never recorded. We should be very, very sensitive in knowing the other child is also sometimes has to take leave from the school because one child has to be taken to the hospital and there's nobody to take care. They also get emotional trauma due to pain of the sibling. They get really affected by seeing the other child uh, crying in pain or not being able to talk. That affects the other child. Then indirect effect on the food and nutrition of this child who's actually not affected with dental caries. And then because the child who has got some symptoms gets extra attention by the family and the doctor, so they also have psychological impact and they get some jealousy factor as well. So all these no records. And so for that, there is a little bit answer. We cannot record all, but there is a little bit of answer with us. That is a technical definition for oral health related quality of life. I've taken it from the FDI website. It was probably 2017 that oral health related quality of life is defined as a multidimensional construct that reflects, among other things, people's comfort when eating, sleeping, or engaging in social interaction, their self esteem, and their satisfaction with respect to their oral health. So, this is generally an definition for the adults, but for the children, obviously, it will add to so many things. So, normally, these are the four domains which are described in any quality of life tool. One is symptoms, second, functions, third is psychological, and fourth is the social impact. Now, for a clinician, why we should be talking about oral health related quality of life? Because it directs us to focus on the holistic outcomes and not just the biological outcomes, which are related to only the tooth or affected tooth. It also makes us focus on the patient related outcomes, including overall patient well being and the satisfaction. The most common tools which have been used for early childhood are OHECQOL, that is oral health related early childhood quality of life tool. It was developed indigenously in India for Indian population by our team in AIMS. Then there's one called as EcoHis, which was developed in USA. Soho 5, mainly developed in UK. Child OIDP, again, is a popular version, the child version of the adult OIDP, and pediatric oral health related quality of life, POQL. So these tools will have definitely many domains, but the tool which we developed, we have covered symptoms domain, functional domain, psychological domain, parental distress domain, family function domain, social domain, and global domain because we considered that child's oral health also affects the general health. And in fact, sometimes the child gets fever or swelling or something. So a global domain. So why do we measure oral health related quality of life? Because it gives you the actual measure of the disease on the population. It helps the policymaker uh, in planning the policies. It helps the funders in planning the funds, and it also gives human development indications, which we would be reading when we read UN documents about different countries' development. So, what all we can add in our clinical questionnaire? We can ask few simple questions like in the last 12 months, how many times or how many days you or your child could not do the following due to one or the other problem in the mouth. So, what are these? Eat properly, sleep properly, talk effectively, avoid avoided going to social gathering or meeting people, or did have a mental stress or had arguments in home or office. There could be one more question that in the last 12 months, how much amount have you spent on the treatment of dental pain discomfort or any other problems in the mouth of your child? Or the other question can be how many days you felt that you are not well due to dental pain discomfort or any other problems in the mouth. Similarly, you can ask how much money you have spent uh, uh, as an indirect cost for dental treatment. So these all will add up. And when you have all the data, it's a time for action. As I mentioned that I'm talking specifically with respect to Indian population. So for Indian population, we should not only record the disease or DMFT, but we should also record quality of life using quality of life tools, and then we should use those tools for influencing our governments and policymakers. So the policymakers can only be influenced by getting adequate evidence. They are not bothered about the prevalence of the disease. They are only bothered that this many percentage of children or this many numbers of children could not eat food properly due to dental pain, or could not sleep, or had to, this many children had to take leave every year due to dental pain from their schools. So that is the thing which influences the policymakers. They are actually not concerned much about the prevalence of the disease. Uh, so, apart from quality of life data, which I mentioned earlier, we should also record economic implications. And then, based on these two, we should have a scientific uh, study or scientific projections to find out what is likely return on investment or cost benefit ratio. So, apart from the disease burden, we must collect data on quality of life, loss of man days, financial burden due to disease, that is direct and indirect cost, and realistic but scientific economic projections. How? That is, that if we spend an X amount of money in year 2022 for prevention of dental caries, or for chloride application, or for patent fisher sealant, there is a likelihood that in 5 years, this many percentage of children will remain pain free, or will be able to sleep properly, or will be able to eat properly, or maybe this many children will not take extra leave from their schools because they remain free from the dental diseases. Similarly, we can also give a projection that today out of the pocket expenditure per family is this much. And if the government spends this much amount, X amount, in these 2 years, in coming 10 years, this much amount out of pocket expenditure will reduce, and this much amount is likely to be reduced for the government expenditure on healthcare. So that's how the projection would work. And then we have one more advocacy tool that is specific to early childhood caries, is that we can use these four sentences for influencing our policymakers whenever we meet them. We can say that ECC is a significant disease in children that has not received adequate global attention. ECC is completely preventable, and it is a silent epidemic which affects most vulnerable population. And if we do not protect the vulnerable population, then it is a sign of inequality in our society. And then, because it is completely preventable, and the people, the children who are affected with this, they cannot speak for their own rights. And we as a society, we as doctors, we as family members have not done adequate care to prevent the pain and suffering in the children. So, this is also a matter of social injustice for those children, those who cannot speak for themselves. So, if we use such tools, if we do good economic projections, if we give good data to the policymaker, then yes, the policymakers and governments are ready to fund. We will have to work hard. So, to sum up, I would like to say that we have not done adequate work in collecting data and presenting facts which the government understands. We can work upon useful indicators and train our professionals in recording them. And third, but not the last and not the least important, but rather it is more important, is more awareness, more influence on policymakers. So thank you very much. And the last line I would like to say that our policymakers and government can give sufficient importance to dental care prevention if we provide them with relevant data as per the public perspective. Thank you very much once again.